I'm very happy to introduce our speaker. George Kolodner has been somebody who's been kind of a go-to person for us in general internal medicine over the years for pretty much all things addiction, and he's incredibly easy to work with. At least that's been my experience. He's been a clinical professor of psychiatry here for many years, and has been very active in teaching residents and students. And I think, if I'm still correct, the students do have an occasional trip to Kolmac Clinic where they may get their one and only exposure to treating addictions. George received his MD from University of Rochester and completed his psych training at Yale, and has been the, I believe, the founder of the Kolmac Clinic here in DC, which is now expanded to multiple sites. So it's really a pleasure to have him speak about a topic that I think is in the news every day, one way or the other, and something that most of us in primary care in particular have to deal with on a regular basis. And whatever we can get from you today, Dr. Kolodner, would be very, very impactful for us. So welcome.
I wanted to thank Dennis for inviting me to speak with you today. And I'm going to be talking about what is a very common occurrence that physicians of all disciplines end up treating patients for, and that's withdrawal management. The technical term now is substance use disorder, for what we used to call chemical dependence. And I find it helpful to think about it as a chronic disease that's marked by acute episodes of intoxication or withdrawal. And that those acute exacerbations or acute episodes really provide an opportunity for addressing the underlying disorder. The treatment outcomes for substance use disorders, even though they have a reputation for being poor, studies show that they're actually as good as with other chronic diseases for those patients who enter in complete treatment. The problem is that most people with substance disorders don't get treatment, and those that start treatment don't complete it. So as you can see in the title, this is going to be an opportunity not just to describe how to treat withdrawal management, but how to improve treatment outcomes for substance use disorders in general. And they really break down into two strategies based on the problems that I put on the other side. One is to improve access and make sure that patients do get access to treatment. And a couple of ways to do that are expand treatment hours and reduce wait times. And the other strategy is to see that people complete treatment rather than drop out prematurely. And the ways to do that are to expedite the reduction of discomfort, because if people stay comfortable, they're less likely to drop out, and also enhance the transitions between the different phases of treatment. And I'll get into some specifics of that in a bit. I wanted to talk about withdrawal management specifically and think of it in terms of the treatment having two halves. The first half is medical stabilization, and the second half is assurance of follow-up treatment. And I put an asterisk there because that's the part that I think is relatively neglected compared to the medical stabilization. And if it is neglected, you can be pretty much assured that you're going to have somebody back in treatment, because the relapse rate for people who don't have follow-up is in excess of 90%. So they're going to be back in the ED or in the inpatient. So here's an outline of what I'm going to present today. The first part is going to be more practical, and I'll go through medication protocols and try to talk about ways of improving medication protocols. I'd like to stop and have a question session at that point, so we don't have to just go through a long presentation without a break. And then The second half I've called for your information. These are things that you wouldn't be in a position to do to change your practice, but you might find them interesting. And that has to do with redesigning the treatment process, but also to tell you about things that we've done in the last year because of COVID, using telehealth to manage withdrawal management virtually, which I never imagined was going to be possible. But once it became necessary, we've really been able to do it and have what I think are quite good outcomes. So here are a couple basics about withdrawal management. This is a quote from a patient that said to me after we'd started his treatment. He said, "If I'd known how easy this would be, I would have come in for treatment much sooner." And I put that there because there is, I think, a somewhat misguided belief that if you make withdrawal management somewhat tougher for people, they'll learn a lesson and they'll be less likely to relapse. And there's no evidence to support that. But I've seen folks that will do that. And here's the opposite. There are so many people who are apprehensive about how hard it's going to be that apprehension keeps them out there and keeps them using. So providing comfort is a very basic element of withdrawal management. That there, as I said, keeping them uncomfortable does not improve long-term outcomes. And also, if you can make them comfortable, they're more likely to stay in treatment. And again, remember, one of the problems with poor outcomes is that people don't stay in treatment, and leaving in the middle of withdrawal to go back to using is not going to improve long-term outcomes. And when it comes to medication protocols, there are two options. The one is fixed dose with PRNs. The advantage of fixed dose, and this is say, for example, 50 milligrams of chlorodiazepine epoxide every 4 hours for the first day, reduced to every 25 milligrams every 6 hours the second day. They're different protocols with PRNs. The advantage of this is it's less complex, and especially if you're dealing with a general medical ward where they don't have specialists available, it's simpler to do. The con is that the symptoms are controlled more slowly, and ultimately you end up using more medication, which when you use benzodiazepines, you'd like to use as little as possible. The second option is called symptom triggered. The advantage of symptom triggered is that you get a better and more rapid control of symptoms, and ultimately use less total medication. The problem is it's more complex, and actually in a general medical ward, I'll go through the specifics in a bit, the staffing doesn't accommodate it because it involves seeing patients and medicating them every hour for the first 4 to 6 hours. And nurses just don't round that frequently on a general medical ward. So now I'm going to go through 4 substances, and for each substance, I'm going to talk about some common mistakes and ways to correct them, and then I'll talk about some new developments that you might not know about. So let's start with alcohol, and one of the things to watch out for just basic elements of it is to identify early. So if you have someone who comes into the hospital, and at least when I was on the staff there, this would continue to happen, and they would seem to all of a sudden start hallucinating or have a seizure, that meant that the early signs were missed. And so being alert to the early anxiety, discomfort, and tremulousness, so you can medicate early, is the best way to prevent serious complications. The other is to stay ahead of the withdrawal symptoms. These people, alcoholics in particular, have very high tolerance. So they need much higher doses of whatever medication you're using. And the goal is to not wait till they're very uncomfortable. It's much easier to stay ahead of withdrawal symptoms than catch up. And particularly once someone's had a seizure, it's too late to prevent that. The other is to restrict lorazepam, if you're going to use benzodiazepines, to restrict them only when you've got liver failure. I've seen that in most EDs and hospitals, lorazepam is the go-to basic rather than using longer term ones. And if people have questions about the disadvantages of it, I can go into that later. But we will, and the other is, is using alcohol for withdrawal management is poor practice. I'm sure that nobody who's listening to me is doing this, but I was horrified when I was on the staff there and would have medical students tell me about surgeons using alcohol in surgical ICU for alcohol withdrawal. And I was disbelieving about that, but I verified not only is it true, but it happens in teaching hospitals across the country. This is a surgical practice for which there is explicit discouragement by addiction specialists such as myself. But I don't know how widespread the practice still is now, but alcohol is a toxic entity, and benzodiazepines are much preferred. So in terms of the new developments for alcohol, benzodiazepines are still the gold standard, and especially long-acting ones, such as chlordiazepoxide or diazepam. But there has been a fair amount of literature and practice using anticonvulsants in lieu of benzodiazepines. The problem is that that anticonvulsants are very effective for mild to moderate withdrawal syndromes, but not for severe ones. And it's our tools to predict the severity of upcoming withdrawals are not very good. So what I've developed, there's no literature on this, but rather than choose between the two, I have for years now used a hybrid where I'll begin with benzodiazepines for the first 24 to 36 hours. And again, using a long-term one, like chlordiazepoxide, it's going to be on board for a week or two. And then beginning day 2, I shift over to an anticonvulsant. The one I use is gabapentin. And I find that allows me to cover both acute, mild, moderate, and severe withdrawal syndromes. There is some work being done in completely eliminating benzodiazepines from the protocol. There's pretty decent evidence that it is effective, but it's not mainstream. And the key to doing that is by adding alpha-2 adrenergic agonists. So the focus for years has been, in terms of the neurobiology, is understanding how heavy alcohol use disrupts the GABA systems and the glutamatergic system. But it actually, in addition, it disrupts the adrenergic system. So we used to think of the symptoms, the adrenergic storm, so to speak, of opioid withdrawal as being very different than the symptoms from alcohol withdrawal. But actually, it's quite, the adrenergic overactivity is a part of the alcohol withdrawal syndrome. And it looks like that contributes particularly to the delirium part of it. So using alpha-2 adrenergic agonists can address that. So that's one new development, is using a different protocol. The other is the recognition of persistent withdrawal symptoms. So the acute withdrawal symptoms that occur in the first few days are the ones that get the most attention. But there are nagging, persistent symptoms, including insomnia, anxiety, mood fluctuations, irritability. And they not only make the people uncomfortable, but these again contribute to people terminating treatment early in the form of going back and relapsing. So what's becoming more and more common practice is to maintain people on these for 6 to 12 months. And the most common ones are gabapentin and carbamazepine. And the kind of doses, gabapentin is the one I use. And generally I'll use about 1,200 milligrams a day in divided doses. If people are very sensitive, you have to cut that down. And as people stabilize, you might maintain them more at about 600 milligrams a day. But that's really improved outcomes. Particularly, the literature about this says that it's particularly helpful for people who have more severe withdrawal syndrome. Moving on to opioids, buprenorphine is now the standard of care. And the unfortunate thing about buprenorphine is that it was overregulated when it came in, so that an ordinary physician who can prescribe as much as they want of more potent opioids has to take an 8-hour training course in order to qualify for using buprenorphine for addictions. There is some political work going on now to eliminate that. In fact, it was temporarily eliminated during the waning days of the Trump administration and then got reasserted. And there are folks now talking to the Biden administration about dropping this. Buprenorphine is a wonderful medication, especially for addiction, but for pain as well. It's a very unique synthetic opioid. It's a partial mu agonist and a kappa antagonist. It's got even though it's a partial agonist, it's got very high receptor affinity, and it's very long acting. Has a very low likelihood of overdose because it has a ceiling effect, and it's not very rewarding. So people don't get a high from it unless they inject it, and that's why the most commonly used formulation is compounded with naloxone. So if people do divert it by injecting, the naloxone will blunt the high. So that discourages injecting. For patients, as you all know, one of the avenues into opioid addiction has been chronic pain. And when you get someone who has become addicted and you want to get them off of their Percocet or their hydrocodone, but they still have ongoing severe chronic pain, buprenorphine is really an excellent agent. It was, before it was ever used for substance use disorders, opioid use disorders, it was used as an analgesic in the form of Buprenex in a parenteral form, and it's still out there. But buprenorphine, the one that we use, is a sublingual. And the other good thing about it is, compared to methadone, there is less of a severe neonatal abstinence syndrome. So, and there's good literature about how it reduces not just the severity of symptoms, but also the length of stay in the neonatal ICU. So it is the medication of choice for pregnant addicts. The new developments with opioids have been problematic. I'm sure you've all heard that fentanyl has essentially replaced heroin in the streets. In addition to that, there are people who try to get opioid pharmaceuticals in the street that are counterfeited, and these are adulterated with fentanyl. The problem with fentanyl is that it remains in the body long enough so that if you, our usual routine with transitioning people from heroin to buprenorphine was that you just have them be off of heroin for usually 8 to 12 hours. They go into mild withdrawal, and you'd start with buprenorphine, and you'd be a hero. They would do everything but hug you because you made them very comfortable very quickly. Doesn't work that way with fentanyl. If you give people, if they come in with mild withdrawal from fentanyl, and after 12 hours, if you give them buprenorphine, you will precipitate withdrawal, and you will intensify their withdrawal symptoms, and they're much more likely to punch you than hug you. And there may, in addition to it getting embedded in the fat cells, there may be analogs. We don't really understand what's out there on the street. But what we do know is it takes 72 hours before you can give these people, from their last fentanyl use, before you can give them buprenorphine. And so what I've developed is what I call a tramadol bridge. Tramadol is a relatively weak mu agonist, but it doesn't have the affinity that buprenorphine does. So when people go into mild withdrawal from fentanyl, you can give them tramadol without precipitating withdrawal, and you can keep them on that for 72 hours until until you can get them onto buprenorphine. So that is I found that to be very useful, because in the long run, keeping people on buprenorphine beyond withdrawal management is critical. If you just do even the best of withdrawal with buprenorphine and taper them off within a week, they're going to have that same, in excess of 90% relapse. They're going to be back and seeing you in the not too distant future. And the literature for buprenorphine is to keep people on it for at least a year. I've had a number of people now who've been on it for, well, we got it in 2003. And there are people out here who have been on it for that long, 10 or 15 years. Usually at very low doses, but it does not, it doesn't have long-term downside. And some people after several years do choose to get off. It can be difficult to get off, but it is possible. There are various protocols for getting people off. The third thing I wanted to talk about was benzodiazepines. And we use a Phenobarb Taper. I prefer that to benzodiazepines, primarily because we do this outpatient. And if you do a Phenobarb Taper and you watch their urines, you know that there should be no benzo in their urine. But if you have somebody who is an Ativan or a Xanax addict, and you're giving them Phenobarb, you don't know if they're continuing to take their agents unless you look at the urine. If the patient can't tolerate Phenobarb or you're uncomfortable using it, chlorodiazepine epoxide and clonazepam are two long-acting benzos that would be good agents instead of phenobarbital. The main problem we see with benzodiazepine, the main area for improvement, is that when people are hospitalized for this and you're limited to a 5 or 7 day hospitalization, often the attempt will be made to taper them in that 5 to 7 days. And you can do that. I haven't seen people seize with that fast a taper, but it is uncomfortable. And what happens when people are discharged, they get a rebound of symptoms and they go back to using. So it's really ideal. It takes us between 4 and 8 weeks, depending on the starting dose. So if we have somebody who comes in with who's been on, say, 3 or 4 milligrams of Xanax for 2 years, we can maybe get them off in 4 weeks. But if you've got somebody that's up to 10 or 12 milligrams and they've been on it for 10 years, you're going to need 8 weeks to get them off. So if you do start people in the hospital, rather than get them off completely, it would be ideal if you can identify yourself or someone out of the hospital who would continue the taper following discharge. On the other hand, it's important to taper. What happens sometimes is people taper down, they get a little uncomfortable and will resist tapering down all the way. And it's easy to get into a plateau where you essentially cross-addict somebody to what was supposed to be the detox agent. So you have to watch out for that. The other thing to know is that these people often have gotten on their benzo, not for recreational purposes, but because they had an underlying anxiety or a disorder, a panic disorder. So you really want to be aggressive about trying to identify that up front, because if all you do is taper them off their benzo successfully, you leave them with an untreated anxiety disorder, which the symptoms of anxiety disorder are very similar to the symptoms of benzo withdrawal. So it's very difficult sometimes to distinguish at the moment. But by taking a history, you can identify if this was there before. So you really want to start them on these other anxiolytic agents as well as therapy before you get them off all the way. The last thing I wanted to speak about was cannabis. There really are no basics on this because we've only recently, relatively recently, has cannabis withdrawal syndrome been validated as something deserving as a diagnostic label. It still is dismissed as there are many people that believe that it's not physically addictive, which there's plenty of evidence that it is. But even the people who acknowledge that it is there's not an under recognition of how clinically significant this is. People don't seize from this, but what they have in addition to persistent insomnia and anxiety and irritability, they have protracted cravings, and it's cravings over the weeks that drive people back to relapse. And you can significantly reduce or even eliminate those cravings by using synthetic THC, dronabinol. Marinol is the brand name. There was literature 10 years ago documenting the effectiveness of the synthetic THC, but we couldn't use it clinically because it is an off-label use of dronabinol, and the insurance companies would not reimburse for it, and therefore it was really too expensive for people to use. But for reasons that I can't explain within the last year, specifically in the last 6 months, insurance companies have been covering the cost. So it's an agent that I've been starting to use. And I'll show you later some of the data from that. This is something I haven't done yet, but as I had said earlier, that one of the things we're learning about withdrawal management is to pay attention to the post-acute withdrawal so that you can keep people on non-addictive agents over an extended period, such as gabapentin for 6 to 12 months. There's a limit as to how long I want to keep people on THC, because even though it doesn't have a high abuse potential when you take it orally, it still has some abuse potential. So I'm interested in getting THC-free CBD to treat my patients on an ongoing basis. There is now pharmaceutical grade CBD out there. As you may know, Epidiolex was approved for very rare childhood seizure disorders. It's extremely expensive, and we're in the same situation with that now that we were with dronabinol before. Namely, it would be impractical and too expensive. So I'm exploring a source for this, but there is actually a little bit of literature when they've used pharmaceutical CBD, and to me very interesting, they've used it in people who were on buprenorphine, and they found that if you give people CBD in a laboratory setting, you can reduce their cravings for opioids, even though this is a cannabinoid. And so that just speaks to the overlap internally between the internal opioid system and the internal cannabinoid system. So that's so new, there's no literature on that. This was going to be a very slow slide. I was going to describe what it was like for us to do withdrawal management on an outpatient basis. But I'll just slide through this, just tell you that it's that we, and this was all before the pandemic, people would call, we'd see them within one business day. They'd come into the office generally the next day, we'd medicate them right away. We'd use our own medications that we had our own supply. They would stay in the office for 4 to 8 hours, and each hour they'd be seen by the nurse and medicated. At the same time, they would participate in outpatient rehab. So we had embedded our withdrawal management in ongoing treatment. And at the end of the day, they'd give them bedtime medications and a prescription to have their own supply. The next day, they'd come back to the office and continue in outpatient rehab. So that's what we've been doing that for 40 years. And our outcomes were really quite good in terms of transition into outpatient follow-up, because we had embedded the process in outpatient follow-up. 80 to 85% of our people would transition. And if you look at the literature for people who were withdrawn on an inpatient basis, only 20 to 45% of those people do transition. And as I said before, the relapse rate in those cases is in excess of 90%. So the terrible prognosis that these people have, the frequent flyers who come back and back, in some ways we contribute, an element of that is that people don't get follow-up after even the best of withdrawal management in inpatient settings. Here is, and what I'm suggesting, and the title is to redesign withdrawal management treatment, because the protocols now are so good, the medication protocols, that outpatient, you can manage almost all levels of the complexity in an outpatient setting. And because the follow-up rates are so much higher in outpatient, what I'm suggesting is that outpatient settings should be used more, and that when you do use inpatient, to increase the focus on making sure that people are going to get follow-up treatment for their addiction. The other way that I want to talk about for improving outcomes has resulted from using telehealth, which is something, as I mentioned before, we were forced into. So we've always done outpatient. We've done it for decades, but now we couldn't see people in person. So we developed ways to do this virtually. So the difference in doing it from in person is, instead of administering and dispensing the medications, I call in a prescription to the person's local pharmacy. And the supervision, instead of being done in person, is done by video by that same nurse. So this is a parallel to the slide I showed you before. Person contacts in the same way, but now they can see the nurse, instead of seeing the next day, they can see the nurse within 1 hour. And the other, and I bolded the differences. In order to do this, you need to have a responsible person in the patient's home who's going to be with them, who commits to following the protocol. And then the medication is sent to a community pharmacy, and it's monitored or held by the support person. Then the nurse does the hourly reevaluation by video or by phone for the next 4 to 6 hours, and the patient simultaneously again participates in the outpatient rehab by video. And then after the first day, the nurse calls the patient daily, and the second day typically a few times a day, and then a diminishing number for however many number of days the patient needs before they're stable. And sometimes that's 3 days, and sometimes, especially with a tramadol bridge, that's going to be 5 or 6 days. So this telehealth improves access in that we can initiate treatment. You know, the nurse can be seen within an hour. If we can get the pharmacy to respond quickly, we can actually start the treatment within 2 hours instead of the next day. And the other advantage is, it used to be that if somebody called us in the afternoon, we'd say, see you the next day. But if they call in the afternoon and they're already in withdrawal, we can begin treating in the mid to late afternoon and not wait till the next day. The other thing with a virtual is we can now do this for 7 days a week instead of 5 days a week. So access is significantly improved with the telehealth. Continuity of care also, I won't go into the details of this, but we only had, of our 6 offices, only 2 of them had the in-person nurse. But now we can do this no matter where the patient is coming from, where in Maryland, where in DC, and we've now expanded this to Pennsylvania, Northern Virginia, so we can see them in any of those geographies. And here are our treatment outcomes. We've had 530 new admissions. We also have had some of our relapse patients, but 530 new patients from last March to this past April. And I have 2 outcome metrics. The first is completion of withdrawal management. And of these 530, 89% completed withdrawal management. One of the things I'm most pleased with is, when in the analysis for this talk, I broke out the second half of the year from the first half of the year, and found that this number had improved from 87% in the first 6 months to 95%. That tells me that now that we've been practicing it, we're getting better at it. And of the people who complete withdrawal management, 94% transitioned into outpatient follow-up. If you look at 95 of all the patients, all the ones that were first initially treated, 85% of all the patients transitioned to the outpatient follow-up, which isn't as good as 94, which is just for people who completed withdrawal management. But still, that's slightly better than we were doing pre-pandemic, and certainly a lot better than the percentage of follow-up that you get with inpatient. Just for your reference, the substance breakdown, 68% of these people are alcohol, 27%. This reduction is consistent with what we've seen of a gradual reduction of our percentage of our opioid patients. If you looked at the New York Times yesterday, had a report that during pandemic, the number of overdose deaths went up, and then presumably most of those were due to opioids. So some now are coming from stimulants because the stimulants are being laced with fentanyl. But I think you have to separate overdoses from use. And even though the overdoses have not gone down, I think that's primarily because of fentanyl replacing heroin. I think that the actual use has gone down, and we have seen even before the pandemic, our percentage of opioids the year before this were 35%. The year before that, they were 45%. So there's been a consistent drop in the number of people presenting for opioid use disorder, which I think is consistent with that the opioid epidemic, so to speak, has peaked. We also see 4% consistently of our folks are benzodiazepine. And I mentioned before about cannabis. This 2% is of the past 6 months. We didn't have any cannabis patients in the first 6 months. Lessons learned, there are patient adherence issues. Having a responsible support person is really important. If you don't have that, you can get in real trouble. And so one of our main reasons for referring people into inpatient is either they're too complex for us or they don't have somebody who can be a support person. We make some exceptions if we think somebody can demonstrate that they're reliable enough to do it themselves, but generally we want that. The other important thing is to have inpatient backup so that when either we triage them at the beginning or if things aren't going as we wanted, it's important to have a backup place. Early on, we had a lot of technology difficulties with getting people online. That seems to have diminished, but it really is important to have administrative support to help get people online because it's really not the best way for our medical staff to spend their time to get people to walk them through how to get on Zoom, which is the HIPAA compliant format that we use. The other problem we ran into is that pharmacies are not familiar with withdrawal management protocols. So the kind of using very aggressive protocols, the kind you use in the hospital, I've always used them in outpatient, but since I had my own supply, I could just give them. Now, if I call a pharmacist and tell them what my plan is, they get very anxious, and some of them have refused to fill my prescriptions because the dose seems just too high to them. So what we've done is to try to break away from the chains, which I was never fond of before anyway, and form a relationship with a network of independent pharmacies where the pharmacist knows us and doesn't get scared by our protocols. The other thing is that the medications we use, some of them are quite old, like phenobarbital or chlordiazepoxide, or even buprenorphine. And some of the chains don't have them in stock. And you'll call them and they'll say, no problem, we can get it by tomorrow, but tomorrow's too late. The person's in withdrawal right now. So the nice thing about the independent pharmacies is that they keep these in stock for us so the patient can pick them right up. So just before we get to questions, just in summary, what I've said is I think that we can improve overall treatment outcomes of substance use disorder by using better medication protocols. We can improve outcomes by making treatment more accessible and reducing dropouts. And I talked to you some about the idea of using telehealth. The reason we could use telehealth was that many of the regulations, almost all the regulations, the state regulations, the DEA regulations, and the insurance restrictions were all relaxed because of the pandemic emergency. And they were relaxed temporarily. And all of these entities are telling us that they're going to reassert these when the emergency is over. And as we've discovered all the things that we can safely and effectively do, there's been a lot of interest in seeing if we can make these relaxations permanent. So there's a lot of work going on in professional organizations lobbying to try to make these temporary things permanent, but that's a big question mark. But I think the world we go back to is not going to be the world we came from, given what we've discovered about the advantages, and the patient acceptance of this is just very impressive, as well as it makes things easier. Or our staff, we couldn't get our staff to come in 7 days a week to do withdrawal management, but it's much easier for me to staff that 7 days a week virtually.